Thank you, Naufal, for introducing the topic. So, as Naufal has said, we have already covered before the radial side wrist pain. And so, when we talk about the diagnosis of the wrist, either in your clinical practice or in exam situation, the best thing for wrist is first in your mind make a compartmentalization where exactly is the pain and divide mainly into three, whether it's radial side, central, or ulnar side. And quite often patient will guide to you. Patient will tell you where exactly the pain is, so you have to ask a detailed question about main complaint, which could be pain. Sometimes it could be other presenting symptom like clicking and locking or sensation of instability, but most of the time it is the pain and patient will tell you where it is. Once you know which side it is, then you have to start with your routine examination. And very quickly, as you're doing your routine examination, you have to come to in your mind, a kind of a differential diagnosis because there are so many causes of wrist pain on both ulnar side, radial side, central wrist that for an MS exam, the examiner would like you to do a specific test having something in differential diagnosis to come to a diagnosis of that particular pathology. So it is not like your MBBS exam where you do exactly same for every case. Here, you will start with a history to point you what condition it likely to be, and then the second aim of your will be quickly start examining exactly same as you will do look, feel, move, measurement, some special test, and to come to, if not a specific diagnosis, at least a good two or three differential diagnosis. And as with any musculoskeletal examination, the key to make a diagnosis is knowing an anatomy of that area. So we'll start our talk mainly today concentrating on anatomy of ulnar side of the wrist, so that we will see how that can be applied for you making uh, a differential diagnosis, and then arranging some specific test investigation for that differential diagnosis so that you can make a definite diagnosis and manage that condition. So that will be our aim. As we already mentioned that we have dealt with the um, with the radial sided wrist pain before. So this area we have already dealt before, uh, and the central area actually uh, can superimpose. So wrist pain can be superimposed. Sometimes the ulnar sided pain can be coming from your central wrist pain. So you have to know all the differential diagnosis for that area. So radial sided, we have discussed in detail what can be the causes for that, and it is relatively easy on radial side compared to your ulnar side. And the main problem is that ulnar side, not only the anatomy is complex, but they are all interrelated to each other. So if you got a TFCC pathology, it could be that it is because of the uh, uh, long ulna, or if TFCC pathology is there, it could be main presenting feature, maybe a distal radial ulnar joint instability. And if there's distal radial ulnar joint instability, it may be causing extensor carpi ulnaris tenosynovitis or subluxation, and they all can be interlinked. So not only the anatomy is complex, but also it is very important to understand how these different pathology are interlinked with each other, and we'll try to simplify it for you so that you can understand this and present in the exam. A lot of people think that this is not an important site to come in the exam, but you will be surprised that, and we will discuss in detail that if you're talking about pain on this area, quite often it could be because of the something else going. So a malunited radial fracture may not present with a central or a radial sided pain. It actually may have no symptoms here, although the cause is here, but the pain may be on the ulnar side. So it is an important concept to understand for your exam and also in clinical practice, that how the ulnar side wrist pain starts, and you have to find out where is the main pathology. As I said, it is very common to get an exam a case of a malunited distal radius fracture, but the problem, the presenting complaint or the problem of patient could be all on the ulnar side, and so the examiner would expect you to know what are the problem on ulnar side and how to manage that cases. So that's an important thing to understand. So let's first understand the anatomy of the um, distal anatomy of the ulnar side of the wrist, so that we can make a good differential diagnosis of that. So we start with the bones um, on the ulnar side of the wrist. So what are we talking about? We're talking about lower end of the radius. We're talking about lower end of the ulna. We're talking about ulnar-sided carpal bone. So any problem with the lunate, any problem with the tricutril, and on top of tricutril, there's another little bone which is not shown here, but pisiform, which is if you see an AP view, it's superimposed, but on the lateral view, it's on the more on side, and then the hamate, and then the two metacarpal which articulate with the hamate. So all these structures, bones, any pathology of these bones can be responsible for ulnar-sided wrist pain. So lower end radius, ulna, lunate. You remember lunate articulate both with the radius and the lower end of ulna, and we will see that. So tricuterum, pisiform, hamate, and fourth and fifth. So this can be any of the bone pathology of this can cause problem on this side. Then there multiple joints which can cause problem on this. So what are the joints on the ulnar side? You have to look for problem. So you can have problem here, radiocarpal joint. So we said already the ulnar joint with the lunate with the radius can cause problem there. If it is a problem of lunate or lower end radius in the lunate fossa, and that joint can be affected. Distal radio-ulnar joint is a separate problem can be there. Radiocarpal joint, we will know how this problem can occur there, and then the carpometacarpal joints. So all again, you need to look for bones, and you need looks for these joints where the problem is, and then make your differential diagnosis. So let's go a bit more detail into these, how these joints are formed and what are the stabilizing structures which can affect these joints and are responsible for differential diagnosis of ulnar side wrist pain. So if you see anatomy of lower end of the radius, you note there is a scaphoid fossa where scaphoid is articulated, and there is a lunate fossa where lunate is articulated. Okay, so on the radius side, you got these two big fossa. But it is also important to know that on the ulnar side of the wrist, this area, which we call a, a notch there, sigmoid notch. This sigmoid notch is very important area which forms your distal radioulnar joint with the ulna, and we will know which part of ulna form that. And this is one of the key factors to assess in your clinical examination, not only the pathology of this joint as arthritis, but instability of this joint causing ulnar-sided wrist pain. So your lunate fossa and your sigmoid notch is important. On the ulnar side, if you see the ulnar anatomy, you all know ulnar styloid, you know the just on the dorso ulnar side, on the border there is an ECU tendons which passes through this groove. And then ulna has got two parts of it. One is we call it a dome of the ulna or a pole of a ulna. You can call it dome or pole of a ulna, but more important is on this side where it articulate with the sigmoid notch, and we call that a seat of the ulna. So this side is the seat of the ulna, and this side is a dome or a pole of ulna, so that you need to understand where the problem could be. The questions come that when we come to